Good morning, everyone. I hope you all are refreshed and ready to jump right in this morning, this Monday morning. Um, I want to just take a moment to let you all know that we have some exciting things coming up here at Archer. We'll talk more about that as we go along. And I just want you all to join me today. And any questions y'all have, you can put them in the chat. And anything that you all want to talk about or have questions about regarding Archer, we have the email address for you guys. Put that right here for you, questions. So that's there. And let's go ahead and get started. Today we're going to be talking about the reproductive system. And the first thing we're going to talk about is pap smears. And just a reminder for everybody, we do have guidelines for pap smears, and this is a screening test. And this test is going to be performed to help any detection of abnormal cervical cells and cancer or precancerous things growing around the cervix. And pap testing is going to involve collecting the cells from the cervix and examining them under the microscope. Now, remember, as nurse practitioners, we don't examine the cells. We're going to send that off to pathology. And we're going to be the ones responsible for collecting the cells. So we're just going to go ahead and look exactly how to perform that procedure. It's going to be using the speculum, if you all recall, performing that exam. These are our guidelines here for cervical cancer. Recently, we've had some adjustments. ACOG, or the American College of Gynecology, excuse me, I can't talk today, and the USPSTF and the CDC, they all kind of set the same kind of guidelines recently. I'm going to be talking about pap testing every 3 years if it's done alone. If we co-test with HPV, that can be done every 5 years. Also, just a difference here, we're going to do cytology testing only for those people in their 20s. So starting at age 21 is when we're going to start screening if you're going to go with those guidelines. Again, these are the most common guidelines that we use for screening. Start screening at age 21. And if these patients, by the time they get to 30, that's when we can start the co-testing. So that's kind of the difference there. And then they have the option of doing that every 5-year test. And then for the American Cancer Society, screenings are going to start at age 25, and we're going to do that every 5 years, or pap testing alone every 3. So again, it doesn't matter. The exams are not going to test you on specific guidelines, but for practice, if you will, you want to think about picking a guideline and sticking with it. But the exams are going to ask you like about co-testing, things like that. They're not going to drill in on a specific guideline. Also, boards do love to test on numbers in general. So not only will we remember the ages for the pap testing for our boards, but also the HPV strains that are the most common. So I have them listed here for you. HPV 16 and 18, those are the most common cervical cancer causing strands of HPV. And then HPV 6 and 11 are those ones that cause those pesky genital warts. So again, just thinking and knowing your different numbers. There's multiple strands of HPV, or human papillomavirus. You guys are familiar with that, but those are the ones that are the most cancer causing and wart causings. Again, right here, I draw your attention here. All right, let's go ahead and talk about cervical cytology. So now we know who gets pap testing, but we need to know what we're going to do with the results, okay? So when the results don't come back completely normal, we're going to look to ACOG guidelines, as that is what most practices and the exams will usually follow. And these abnormal findings are going to be grouped into cytology, and that is individual cervical cells is what that's referring to, and histology, which is actually looking at tissue as a whole. And so for cytology, we can have any of these come back. You can see all these letters of our alphabet soup here. But the most common by far is going to be ascus. You can see that in your lower left hand of your screen. This is atypical squamous cells of undetermined significance. So I just want you to think about that's going to be your most common one. And then you can have different ones. We cannot exclude LSIL, which is low-grade squamous intraepithelial lesions, or HSIL, which is high-grade squamous intraepithelial lesions, adenocarcinoma in situ. So depending on cytology, we're going to manage these patients in different ways. So if you just get ascus coming back, that's going to be a clue that we probably need to go ahead and get some co-testing done, most likely. And these patients are going to be referred to gynecology every single time, these ones that I have listed here on this slide. So this is a really important slide for you to know when to refer, okay? So ascus can often be caused by HPV, but also it can be caused by things like intercourse, tampons, anything that's going to cause a cellular disruption in the vaginal cervical area. So really ascus just simply means that some of the cells did not look uniform under the microscope. So this does not just automatically mean we stamp a cervical cancer diagnosis on these patients. We need to do some further look up and work up. So also we're going to have that HPV test run. If it's positive, we're going to refer those patients out for a colposcopy. And then also that is going to be a deeper look at those cervical cells and possible biopsy to confirm findings and treat accordingly. So you see here, I have it listed, ascus with HPV. That's going to be referred to gynecology. If the HPV is negative, a lot of times we can just repeat the PAP on the normal timeline, or sooner if the patient and provider and wants to talk about peace of mind, or if they just want to recheck. And this is going to be an informed decision between you and your patients. And then referring to the slide here again, I've got them listed: HSIL, AGC, AIS. These are all going to need prompt referral to gynecology. LSIL, that low squamous cell, that one's going to be requiring an HPV co-test as well, just like the ascus. And if they have that, then we can repeat the PAP test in 6 to 12 months. If they have HPV, though, positive, that's going to also, again, just be referred out to gynecology. So again, if you get some of these, I would go ahead and try to get a co-test run on that, and then see where we can send them. And if we get into these other type of things, like the AIS, adenocarcinoma, adenocarcinoma in situ, any of these other things, these need to be sent on to gynecology immediately and not mess around. So also cervical cell changes, we're just going to talk about histology. We're going to talk about SIN1, SIN2, and 3. Again, talking about those staging. So if you see cervical cell changes and you see anything like SIN1 listed on that PAP report, then you can probably just repeat the PAP in 6 to 12 months. But if you start seeing SIN1, 2, or 3, we're probably going to need to go ahead and send them on over to gynecology. So again, if you're not sure, you can always refer it out. So right here, primary care is going to consult the guidelines and make appropriate referrals. That's the main thing that you need to really pay attention to on all of this alphabet soup here that I'm giving you, is know when to refer. The other thing that I want to just draw your attention to, why did the PAP guidelines change in the first place, is because we are now helping to reduce rates of cervical cancer. How are we doing that? By providing vaccines such as Gardasil. So the HPV vaccine, it is now approved for ages 9 to 45. And so we're going to be recommending to all of our patients in that age group, trying to decrease the risk of transmission of HPV. So just thinking about these types of things, again, these are not things that you have to memorize, but these are just things that you need to know when to refer. All right, vaginitis. We're just going to go ahead and move on to vaginal infections. Vaginitis can be caused by many things. Some of the most common ones are your big 3 infections: bacterial vaginosis, candidiasis, also known as yeast, or trichomoniasis, also known as an STI. And remember, I want you all to put in the chats, only one of these is an STI. And I've got it listed here, but I want you all to think about which one's the STI of those big 3 infections, because the other 2 are not, okay? BV is going to present with an odorous fish-like smell. It's going to have frothy green discharge. It's going to have vaginal irritation. It's going to be caused by overgrowth of bacteria in the vaginal vault. And BV is going to be treated with metronidazole. While we're on that same topic, you all got this. Very good, Jasmine. Trick is going to be your STI. It's also treated with metronidazole or Flagyl. Now, who can tell me on here one of the key critical concepts that we want to educate our patients on if we're prescribing metronidazole or Flagyl? Who can tell me what the patient really needs to avoid if they're going to be prescribed that medication? Y'all can put it in the chats. So also, trichomoniasis going to be treated with Flagyl. We also might be doing, a whole STI panel with that. Oftentimes soreness, white discharge, pain with urination. We can see those types of things with trick. And then a yeast infection is going to be that textbook white, chunky, curd-like discharge. It's going to have itching. This patient will have, maybe some redness and irritation if you examine them. And there are some over-the-counter treatments like Monostat. They work pretty well. Or if it's something really big and nasty looking, then we can go ahead and consider prescribing diflucan. So just think about on there what your different treatments are. And who can tell me, who can put in the chats, if you're going to prescribe Flagyl, what do we need to educate our patients on? Because remember, BV and Trick are both going to be treated most likely with Flagyl. I've got it right here if you need a little hint. Why are we avoiding with Flagyl? And why? I'll give you just a minute to think about that. Absolutely. So if the patient takes alcohol, it's going to give them a like anti-abuse type reaction with the Flagyl. And so we want to advise our patients to stay away from alcohol for at least during their treatment and a few days after. So they're going to get pretty sick. So just making sure that we tell them to avoid alcohol while they're taking that medication. So great job, guys. All right, so vaginitis. With any vaginitis, we're going to want to be providing our good patient education. So I've listed here some education pieces that you're going to want to talk to your patients about, like washing with warm water, if they're going to use soap, something very, very mild and unscented. If they are also going to want to change out of wet clothing in a timely fashion and not wear tight-fitting clothing to bed. In fact, if they can go even without underwear at night and kind of air things out, that's best. Otherwise, cotton, loose-fitting underwear. Also, I want you to think about how we're going to test for vaginitis. We can do whiff tests. We can do the KOH test. These can be done in the office. Another option is going to be having that vaginal swab sent to the lab. So if you're just not really sure this patient has discharge or they have discomfort, we can always just send out a swab to try to kind of like isolate what's going on and treat them accordingly. So again, just thinking about education to prevent, and then also education if they actually develop the infection of what we're going to educate them on. Those are going to be some critical things to know for your boards and in practice. All right, atrophic vaginitis. Another term for this is urinary syndrome of menopause, or GSM. And vaginal atrophy is going to be caused by most likely hormonal changes. Also, patients, if they're having like chemotherapy, anything that can cause the issues for the patients to have dryness and inflammation of the vaginal walls. These are types of things that the patients can really complain of. And so for treatment here, who can list in your chat box, what is our gold standard treatment for atrophic vaginitis? I want you to think about what you would treat your patient with. So I want to talk about symptoms while y'all are thinking about what we're going to treat with. Symptoms are going to be including things like dryness, itching, painful intercourse, vaginal discharge, urinary symptoms such as urgency and frequency. So, if you're not sure on this patient, maybe we do need to order a UA. Maybe we do need to perform a pelvic exam, because we just need to make sure that that's all this is, because it can kind of present in different ways. So estrogen, absolutely. That is going to be your first line treatment. Jasmine, you were on a roll today. Great job. So estrogen therapy is going to be our gold standard, specifically topical estrogen. So things like vaginal creams, rings, and moisturizers, and these are going to deliver estrogen in small doses to the actual vaginal tissue. They're not going to give the patients those systemic estrogen side effects. It's going to be safe for long term. And so remember, this vaginal estrogen doesn't carry a cancer risk. So almost any patient is good for its use. You don't have to have it coupled with progesterone. Remember, if we're giving them oral or systemic hormone therapy in any way, then they have to have progesterone with it if they have an intact uterus. You guys remember that? But if they're on vaginal estrogen cream, we don't have to do that. So this is really a great option. Even patients who are not good candidates for estrogen in the form of systemic estrogen can take it this way. Also, non-hormonal moisturizers and lubricants can really provide symptomatic relief of the vaginal dryness. There's a gel called Replens on the market. I prescribe that a whole lot. That's non-hormonal. So things we can give them in addition to the estrogen, just trying to give them plenty of lubrication to help them. If this is a really severe case, or they just seem really irritated and they're not getting better with the estrogen, we can send them on to GYN or other places and get laser therapy or the vaginal rejuvenation. You guys have probably seen that advertised around in your area. So that is going to be one of the treatments for atrophic vaginitis in severe case. So all right, let's talk about PCOS, okay? PCOS stands for polycystic ovarian syndrome. This is a very confusing thing. We don't really well understand PCOS, but we're learning more about it. Some of our common symptoms are things like irregular menstrual cycles. The androgen levels get really high, so those patients will have like hair in unwanted places. They'll have acne. They can even have infertility due to, a lack of ovulation. So this is something that is multifaceted here. This is something that can be really difficult. It's kind of one of those unseen things that patients will sometimes have that takes a little bit more workup and extra care. To diagnose this, you're probably going to be working with GYN because they're going to be having to meet the Rotterdam criteria. We can think about this with the oligo or anovulation, so decreased or not ovulating at all. Also, biochemical signs of the hyperandrogenism, and then polycystic ovaries noted on ultrasound. So this is the Rotterdam criteria. They have to have 2 out of the 3 to be a candidate for a PCOS diagnosis. And then also thinking about your treatment. This is a patient that is really going to need multi-layered care, if you will, because this PCOS can cause a whole host of issues. It can be cause metabolic syndrome. It can cause insulin resistance. So some of those patients are going to need to be watching their carbs and sugars. Some of them might even be on metformin to help with that, even if they don't actually have a diabetes diagnosis, although PCOS increases chances for diabetes later in life to over 25%. Same thing for heart disease, increases the risk of heart disease as well. Those with PCOS, metabolic syndrome, all these things kind of hold hands. And so also, if this patient is trying to conceive, you are going to want to help with fertility treatments. Maybe they do need to go to GYN or the fertility clinic, depending on their age and what's been going on with them. Also thinking about oral contraception that's going to help regulate their cycles. Oftentimes these patients will either bleed too much or not bleed enough. And so we're really just trying to help control their symptoms. There's really it's more of a treatment versus a cure for this. So this is something that you're going to really want to get a detailed H&P for. This is something you're going to want to make a diagnosis by exclusion. Have you checked their thyroid? Have you checked for an androgen secreting tumor? These things are going to be really important, and it's going to be more of a process of elimination to get other things ruled out so that you can rule in PCOS. So again, this is going to be one that maybe you're probably helping to kind of co-manage. All right. Ovarian cancer, I'm just going to make a quick little note here about that. It is a silent killer. It's very hard to test for. We don't really have screenings for it routinely, and this is often found in the later stages. This can be deadly, deadly, deadly because oftentimes it is found like later on, and symptoms will be very non-specific. And so, things like anybody who has unexplained weight loss, that needs to be tracked, treated, and monitored and followed up very closely. Anybody who has, abdominal or pelvic pain, again, very vague symptoms, feeling of fullness, changes in bowel or bladder, all these things should be really just like starting to raise up the red flags, not only for ovarian cancer, but other very, complex things, other cancers that we can find. Because again, this can become out of hand very quick. Diagnosis for this is going to be ultrasound, CT scan, sometimes tumor marker workup, and then overall survival will depend on staging. So really just paying attention to, signs and symptoms. If you have a female who has intact ovaries, just keeping this on your differential list. That is something that I just wanted to kind of draw your attention to, because it's not always super easy to detect. And it's important that we always investigate non-specific symptoms when patients come in. So just a little side note there for you. All right, I'm going to just briefly talk and touch on menopause here. Who can tell me what menopause is? What does it define? What defines menopause? So I'll give you just a minute to put that in the chats of what defines menopause. So that's right, absolutely. So menopause is that natural biological process that marks the end of menstruation and fertility of women, and there it's going to be defined as no menstrual cycle for 12 months without medication, right? So if the patient has some sort of medicine that they're on, may exclude them. But that is what menopause is defined as no menstrual cycle for 12 months. Average age is around 51 years old. This is going to be a decline in reproductive hormones, particularly estrogen and progesterone. It can lead to lots of physical and physiological changes. So first of all, we have 3 stages of menopause. I have them listed here for you. Perimenopause, it can last up to 10 years prior to actual menopause. This is the transition phase leading up to menopause. Hormone levels will start to fluctuate, menstrual cycles could become irregular, and symptoms might start to appear. We will then have the menopause itself, where estrogen and progesterone levels completely drop and ovulation ceases. The patient will go through a period of 12 consecutive months without a cycle. And then after this time, patients will be considered postmenopausal. They will no longer have any menstrual cycle, and their hormone levels should start to stabilize. Often symptoms will diminish over time. This is going to be something that we're going to definitely want to be asking about, monitoring for, and treating symptomatically for our patients, because I have a lot of women that come into my office very irritated, frustrated, and upset because they just aren't feeling well while they're going through, those menopause stages and changes. So just be mindful of that as providers. We really can help to increase our patients' comfort level. Also, one other thing that I'll mention about menopause is our symptoms, and the patients, these can vary widely between every person to person, but hot flashes, night sweats, vaginal dryness and atrophy, like we just talked about, mood changes, libido changes, sleep disturbance, and also an increased risk of osteoporosis. So I have my little lady here working out, showing that we always need to be encouraging that exercise during this time, specifically strength training, to try to prevent osteoporosis. Lots of different treatments. Some of them are even found over the counter. You'll see, evening primrose oil. You'll see black cohosh. You might see soy derivatives, and these are often helpful for patients. But just one word of caution that I would say is that a lot of times these statements are not evaluated by the FDA. You want to really know what's in it. We really want to document when we're doing those medication reconciliations of what our patients are exactly taking, because it may interact and with some of their either prescribed medications or over-the-counter medications that they're taking. And so just a word of caution to you and your patients of just, knowing exactly what they're taking, and, they're not always regulated. And then the mainstay treatment as far as like what they can get from us will be that hormone therapy replacement. So some sort of combined estrogen progesterone therapy. These can often help relieve some of those symptoms. Also, we can give these treatments orally, transdermally, or vaginally, like we just talked about. Now, we talked about that you can't give estrogen without progesterone. Okay, why is that? Who can put in the chat box? Why is that? What can it cause? Like, why, if a patient has an intact uterus, we cannot just prescribe straight estrogen? Why would we have to have progesterone in it? You have combo pills, you have progesterone only pills, but there's not just estrogen only pills for like birth control. That's an example right there. Who can tell me why we don't prescribe it without progesterone for a patient with an intact uterus? While y'all are thinking about that, I'll just ask you, or I'll just mention here, SSRIs, if the patient, if hormonal therapy is contraindicated or just isn't a good candidate, the patient's not for hormone replacement therapy, then we can think about like low doses of SSRI, specifically Prozac. And then also hot flashes. It can help with that. It can help with their mood, kind of give them more bang for their buck. And then last year, we actually got a new medication called Veoza. This was introduced specifically to target hot flashes. That's right. Absolutely. You all have got this in the chats. Endometrial, it can lead to endometrial cancer, but endometrial hyperplasia is how it's going to start off. That lining just gets thicker and thicker and thicker and cause dysplasia in the uterine lining. And then absolutely, that's what we're concerned about, is leading on to endometrial cancer. So you guys got that. Just knowing that we don't ever give estrogen alone in patients with an intact uterus. Okay. All right, so let's talk about Annette. We're going to go through a couple questions here. She's a 48-year-old female, and she comes to the Women's Healthcare Clinic for care. And she's going to complain of dysuria, odor, and a thin gray discharge. And a pelvic exam is performed, and samples of the urine and vaginal swabs are sent to the lab. The urinalysis with culture is negative for a UTI, and the vaginal swab shows some clue cells. What is your first differential diagnosis? Absolutely. You guys got this before I even finished the question. That's right. It is C. It's bacterial vaginosis. You got it. So clue cells go with BV and that thin gray discharge. And this is just a good textbook example of BV and how you'll see it described. All right, we're going to take just a minute for a little commercial here. We have some exciting things coming up at Archer. As I mentioned at the very beginning of the webinar, we have a live online 3-day review coming up July 19 through 21. A lot of your favorite instructors will be there. There's several of us teaching. So just to kind of help break up the monotony, we have live chat support as well during it. And then it gives you 30-day access to the recording. And for $50, it's for all 3 days. Friday is a full day, so you'll want to block your schedule off from like 8 to 5 that day. But then Saturday and Sunday are in the mornings. They're half days, so depending on your time zone anyways. And that is going to be something that you can do and still get a little bit of weekend time in. And again, $50 for all 3 days. That's a really great deal. We have a Q Bank. Again, everybody should be signed up for the Q Bank, regardless of when you're taking boards. Just starting to practice some of those questions can be really helpful. We're giving away a free 30-day trial right now. After that, it's $29 for 60 days of access, so that's less than $15 a month. We currently have over 1,550 questions on this Q Bank and adding to it every week. And then also just the QR code will give you some more information for both of those things. We are still running the tutoring and the mentoring sessions. If you guys have questions about that, feel free to drop us an email. And then we also have some study groups and some Facebook. On Facebook, we often will put questions of the week or different topics that we'll cover there for you. So again, check us out on social media, check us out on the QR code. And again, just think about all the things that we're offering that's coming up. And again, these are all really great resources for those who are getting ready to take their boards, or maybe you're just starting in NP school. And this will be a really great time to kind of hone in on the areas where you maybe felt like you missed in class or didn't get, all the details that you wanted to get. This is a really great way to study as you go along. So again, just some really great offers for you there. And I will come back and leave this link up for y'all a little later. All right, we're going to move right on to male reproductive system. Again, just keep putting your Q's and A's in the chat. I really love to interact with all of you guys. Y'all are doing a great job and really on a roll today. So let's keep it right up. Our second half of our review will be about conditions affecting those with male anatomy. And then here is just a picture here. You guys can reorient yourself as needed. All right, so we'll start with the prostate, just the structure and function here. This is going to be that walnut-shaped organ. It sits below the bladder and in front of the rectum. The main job of that is going to be to help produce the seminal fluid and help to transport the sperm through the urethra. And remember, we're going to mainly assess this. We can assess it with things like ultrasound, but our tool in the office is going to be a digital rectal exam where we're going to actually gently palpate and assess the size, shape, and texture of the prostate. All right, benign prostate hyperplasia, BPH for short. This is a very, very common condition that often happens. How about symptoms? I didn't put symptoms on this chart because I wanted you all to be able to list those. So you all can start listing away in the chat as we continue talking. Thinking about symptoms of BPH. Y'all can put those symptoms of BPH in the chat. All right, we're going to want to check things out. So absolutely hesitancy. Yeah, what else? We're going to want to start checking things out if their patient starts complaining of any of these symptoms that you all are listing. So thinking about difficulty or hesitancy to start urine. What do you think about the stream of urine? Do you think that's going to be weak or strong? Also, patients may have, that's right, weak urine stream. Absolutely. They may complain of increased urination frequency or difficulty urinating. So the first line is going to be that urinalysis. We're going to want to check that out. But urinary symptoms in males, anatomy should be starting to tip you off to at least include BPH in a differential diagnosis. We're going to want to check things further with a digital rectal exam. And if we're going to be feeling for that walnut-shaped mass, and that normal prostate is going to feel smooth, and you can differentiate between the two different lobes. However, with BPH, some of the descriptors that exams will sometimes ask you about are like rubbery, enlarged prostate. Those are some keywords that you want to think about. So remember, if it's smooth and you can feel the lobes, that's probably going to be normal. If it's enlarged and rubbery, that's going to probably describe BPH, okay? Now, the DRE and the UA, these are not going to be enough to diagnose BPH alone. We'll do some tests. We're going to check a PSA, might want to check a CMP for renal function, right? Anybody who's having difficulty with their urination, we're going to want to check that out. And we're going to evaluate for prostate-specific antigen, or the PSA. And this test should not be performed solely to diagnose BPH, but rather to help rule out more serious etiologies like prostate cancer. Okay, the PSA can be a screening test for prostate cancer. We'll get to that in a minute. All right. Some things that I want to talk about on the PSA. The normal PSA level is considered below 4. So that's something to keep in mind if you do order it. If it's above 4, these patients are going to get sent off to urology for further workup and find out exactly what's making that prostate PSA level go higher. Sometimes with BPH, we can just monitor the symptoms. If we do determine that that patient has BPH, we can help with lifestyle changes like taking out caffeine. We can help weight loss, things like that. Moderate cases, we want to start thinking about medications. So things like Flomax is going to be our tamsulosin. That's going to be our first line treatment. We're going to want to relax that smooth muscle in the bladder and effectively decrease those urinary symptoms. And then another one that you can use, again, still first line, it takes a little bit longer, but just how it works is finasteride or Proscar. And that's a 5-alpha reductase inhibitor. It actually helps to reduce the size of the prostate. So that's why it takes a little bit longer to work. But again, very effective. But think about reductase reduce. That's a way that you can remember that drug class. More severe cases of this, urology referral. If we see any structural issues, again, going to be probably sending them on to urology for a little bit, more of a workup there. We can, refer patients for surgical procedures and the transurethral resection or the TURP procedure. Those are all some just common treatments for like severe cases of BPH. It's going to be some sort of surgical intervention. All right, we're going to move along. Priapism, that is going to be an emergency. All right, this right here is what happens when an erection lasts over 4 hours. Now, who can tell me what the #1 cause of a long-lasting erection that will not go away? Y'all can put that in the chats. This is a prolonged and painful erection. It lasts for 4 hours or more. And if it lasts over 15 hours, then that is probably going to be a surgical intervention. Okay, so these patients need to go to the ER for any erection lasting over 4 hours. Sometimes they can give them an injection. Again, not saying that the treatment is fun, but it's better than the surgical intervention. So sending them off at the 4-hour mark, educating your patient. If you have an erection that lasts for more than 4 hours, if you're going to be prescribing those erectile dysfunction medications, right, it can have the opposite effect. So when we're prescribing those, we want to educate our patient of what time they would need to go and seek emergency care. Okay, sometimes other things like alcohol or illicit drug use. So all of those things can cause it, but the other 50%, like the ED medications and the alcohol or the malignancy, those account for 50% altogether, but the other 50% is actually going to be sickle cell disease, and that is going to account for the other 50%. So that's going to be the most common cause. Okay, and so just think about this. That would be a differential diagnosis if your patient, comes back to your office like, hey, I was in the emergency room for this, especially if they're not on ED meds. So back to the treatment here, they can aspirate, they can irrigate, they can numb the penis and use a large gauge needle to separate and aspirate the trapped blood, and then irrigate with some saline. So again, if conservative treatments don't work, this patient may need surgery. So that's why we give them the 4-hour mark. All right, ED on the opposite end of the spectrum here. This is just trouble achieving an erection. I have listed all the risk factors. This is a multifaceted disorder here. One of the things that I really like to do with my patients is use a questionnaire. That way it just helps to kind of tease out that awkward tension in the room, because if they're answering the questions on paper, then they're not having to look me in the eye and answer all the questions. So, this erectile dysfunction questionnaire, the International Index of Erectile Function Questionnaire, that is a great tool. And so it will ask questions like, how long can an erection last, or is the problem stable or getting worse? So again, versus them talking to me about it, they can just answer the questions on the paper and I can look over it. So patients will often find that's easier to open up and kind of get us on the path to open the discussion. And then also, we're not going to skimp out on the diagnostics. If a patient has ED, we're going to check out their mental health. We're going to look for abnormal vital signs like hypertension, blood tests to screen out for diabetes or kidney disease. Again, all of these things can be causes of ED. They can all kind of go up together. Maybe they have depression and diabetes, right? Double whammy there. So just looking for any underlying reasons or causes that can cause ED if you are doing a workup for this. All right, some of the treatments for ED. After all these assessments, all the labs, and you're not finding any reason why the ED is occurring, sometimes there's no physiological cause. It can be psychological. So in terms of treatment, you're really going to want to talk through these things with your patients, okay? Patients will often have a lot of success with lifestyle interventions. Remember, a lot of the things that we're really recommending for these milder to moderate cases, our first line treatments are going to be lifestyle changes, things like hypertension or, ED, whatever it be. If it's a milder to moderate case and we haven't started anything yet, sometimes our first line treatment will just be simple lifestyle changes. Do they need to exercise? Do they need to lose weight? Do they need to get their blood sugar under control? Do they need to improve their nutrition? What can we do to help them with this? Patients will often just opt for psychotherapies, even first line, instead of jumping straight to medications. So if you have a patient that really needs to get their mental health under control, or this is maybe affecting their mental health, getting them with a therapist, that would be a really great first start. Often some patients are ready to just jump right into treatment. We can still, again, first line treatment, use medications if that's what, as in the patients decide during our shared decision-making time. But we can talk to them about things like Viagra, Cialis. These are going to be your PDE5 inhibitors, and these are going to be your first line treatments for ED. Now, who can tell me on here why taking nitrites for chest pain is contraindicated with a PDE5 med like Viagra? Who can tell me that? So let's put that in the chats, because this is a really important teaching point. So these medications, I want you to think about, what did nitrites do? They're something like a nitroglycerin. They're taking that for like a chest pain. And so they're taking something like a Viagra. What do both of those medications do? They're both going to help promote vasodilation. That's right, absolutely. So the vessels are not just located in the genitals only, right? They're throughout our whole body. So they're going to promote that vasodilation, and they're going to dangerously cause low blood pressure or hypotension. Absolutely, that's right, Jasmine. You've got it. That is why they're going to be contraindicated. So again, ruling out other things, including doing a little heart checkup before we start prescribing these. And again, if our conservative measures in family practice aren't working, we can refer to urology. They can help patients with things like injections. There's devices they can use, and then also surgical intervention as well. So again, just kind of knowing the basics here for your first line treatments, and knowing that nitrates are contraindicated with your PDE5 drug class group, you should be good to go on that. Ballantitis, that's going to be an infection of the glands, and oftentimes this is just inflammation of the glands or the head of the penis. This can be caused by a fungal or yeast infection and can be primarily seen in those who are uncircumcised. Poor hygiene, irritants like laundry detergent, catheters, these are the most primary causes of this. Patients will often complain of things like soreness or itching, a thick white discharge, tight or reddened around the foreskin, and painful urination. So again, if your patient's having urinary symptoms and they're, you may check them and do a little exam. One big problem that can occur from ballantitis is something called phimosis. And I have this in the warning box for you guys. Who can tell me what phimosis is? This can be an emergent condition. If it progresses to something called paraphimosis. And what happens is the foreskin becomes very tight over the glands of the penis. It can lead to something called paraphimosis, which is when the foreskin is unable to be retracted. And that can, again, cause urinary issues, right? And this is urgent intervention if the patient develops this continue. So just thinking about when you're going to send them, when to refer, okay, for this one. Ballantitis, if they don't have the phimosis or the paraphimosis, I'm sorry, I can't talk today. If they just have strictly ballantitis, you might note sores on the glands, swollen lymph nodes, foul odor. It's essentially an infection, right? And so diagnosis will mainly be clinical, but we can rule out an STI, a UTI. These are going to be really important to provide as part of our workup. And then treatments will be improved hygiene, changing their laundry detergent, using cotton underwear, things like that. And then also topical antifungals. And if the infection is severe, you might want to add something like an oral fluconazole to the mix, a topical hydrocortisone to help with the inflammation. So if it's constantly reoccurring, these patients are probably going to have to go to urology for some sort of circumcision or revision. So again, just thinking about balanitis, what it can lead to, and what is urgent versus what is emergent. Okay, that's again, just thinking about that. You should be good for balanitis. Peyronie's disease, excuse me. Scar tissue builds up and becomes painful. The penis will curve, bend, reduce in size. This can be acute or chronic. Oftentimes we start with treatment with medications. These patients will most likely go to urology. It affects middle-aged men, but we can start our own workup with an ultrasound, and that can go on to urology with them. So if you suspect this, I'll probably go ahead and just get an ultrasound and refer them on to urology. Okay, cryptorchidism. That is undescended testes in little tiny babies. This is often, or this will be happening at birth here. It can be very common. And then usually gestational age, like around that 6-7 months time frame, the patient or the baby will start to develop more, and those testes don't come all the way down. Oftentimes, this affects more of the right testicle, but it can be bilateral. And then risk factors will include things like premature birth, low birth weight, maternal obesity or diabetes, alcohol consumption, smoking, and a family history of these. And we don't really see a lot of, symptoms. But again, it's just important when you're doing those well baby checks that we're taking those little diapers off, checking and making sure that we feel the testing in the scrotum. And really and truly, a lot of times we're just going to watch and wait. These are usually going to, spontaneously resolve within the first 3 months of life, and nothing happens. However, around a certain age, we need to start thinking about referring the patient out, the little baby out. What age would you all say needs to be referred out? Because this can lead to infertility if we don't act aggressively after a certain age. Okay, over 6 to 10 months, all right? 6 to 10 months, surgery is going to be considered. So that's right. If your little 3-month-old, 4-month-old there for their well child visit is not starting to show signs of the testicle coming down, then we need to start thinking about a consult at that 6 to 10 months, because they can have infertility later on in life. So that's something that you want to think about, something that you want to plan for, something you want to go ahead and educate the patients for, so that on month 6, mom's not surprised and hysterical because, all of a sudden we have to treat this thing aggressively. So just educating your patients on that. You can order an ultrasound. If you don't feel the testicle in the right spot, you can order an ultrasound for this. So this is something that you want to think about. Also, if this isn't treated, it can also give a higher risk for testicular cancer later in life. So again, after that 6 to 10 months of age, we really start treating this aggressively, okay? All right, so hydrocele. This is something that you're going to see. And a lot of times this is self-limiting. This will be even present at birth in those little babies too, or as a result of injury, infection, or inflammation of the scrotum in an older person. Hydrocele is just simply a fancy word for saying a fluid accumulated around the testicle. And the main symptom of this, there's a hint on the slide, is painless scrotal swelling. And so your checklist for physical exam is going to be painless scrotal swelling, inability to palpate the testicles, and finally, take your pen light to the scrotal sac and see if the light shines through. If the light shines through, that's that transillumination, and you have successfully diagnosed a hydrocele. So that is fluid. That does not mean there's no solid mass. So you are going to be able to differentiate between a hydrocele and something else. If you are not sure at that point, you can always order additional imaging, okay? We weren't born with X-ray eyes, so we can order X-rays, we can order ultrasounds. So when in doubt, check it out. A lot of times hydroceles will resolve on their own, but if they're not, then we can send them on for a surgical evaluation. So just thinking about your off exam and the transillumination, a collection of fluid, and then what imaging you can order to confirm the diagnosis and where you're going to send them. If it doesn't get better, you should be good for hydrocele. Okay. All right, varicocele, often described as what? Put what it's described as. I have a little hint here for you on the slide. This is an enlarged blood vessel on the scrotum. I like to think about varicose veins, right? Sometimes we see varicose veins on the legs or whatever. They're essentially the same thing, just in a different place. That's right. They're described as a bag of worms. Absolutely. So these are going to literally feel like a bag of worms. And the most common symptom is this going to be a dull, achy pain in the affected testicle. So remember, hydrocele is going to be painless. This one's going to have a dull, achy feel and feeling heavy. And then physical exam is easy enough. Larger, moderate varicoceles will have that bag of worms feel on the palpation, and smaller ones might need an ultrasound. So again, you can see if we're having testicular or scrotal issues, our ultrasound is going to be our first line for all this stuff. Varicoceles can result in infertility, so treatment will be important. These patients will be managed by urology. They're going to perform the surgery to correct it. So just some things that you need to be mindful of is if they have, if they're a smoker, we can help decrease the risk of developing this. If they have a venous malformation there, do they have a venous malformation elsewhere? So just some things to be mindful of if your patient does have a varicocele. But again, first line workup is going to be order that ultrasound and send them to urology. Spermatocele, these are going to be a cyst on the epididymis, the area that stores the sperm. We really don't know why this happens. It's pretty uncommon, and patients usually don't have that many symptoms. Spermatoceles are an incidental finding on physical exam a lot of times, and it's when we feel a painless lump, or maybe the patient comes to you for a painless lump. It's going to be separate from the testicle, and I have this listed here because testicular cancer doesn't always feel separate from the testicle. But again, we're going to order an ultrasound for this one every time, because anytime we find a lump, that can really raise a lot of red flags, and nobody's going to sleep until we confirm a spermatocele over testicular cancer. So we're going to get imaging to confirm this. And unless it's causing some sort of significant issue like pain or heaviness, we're going to let these ride. They don't really cause a lot of problems, and cyst removal can be performed if necessary, though. So again, those testicular issues, we're going to order the ultrasound for first line. Going to just stop here and touch on cancer for just a moment. Two male anatomy specific forms of prostate and testicular cancer. Okay, one of the most common cancers diagnosed in men is prostate. These usually are older men, and it usually is a slow growing cancer. This one right here can be caused, it doesn't have a lot of symptoms, but it can be caused of like obesity. African American race can be a higher risk. Starting sexual activity at an earlier age. These can all put you at a little bit higher risk for prostate cancer. And a lot of times patients won't have a lot of symptoms with this, but they might have difficulty urinating, blood in their urine, lower back pain, pelvic pain. So again, these kind of all are just vague symptoms. Same with the ovarian cancer. So we're going to just kind of do some more workups, find out what's going on. A lot of times the prostate will be described as hard and lumpy. And again, we talked about those other more benign findings of the prostate. This one is going to be more concerning. So the digital rectal exam, if the prostate feels hard or lumpy, we need to investigate further. And we're going to order that PSA. The PSA might be 4 to 10 or even higher, or any value that's increased 25% over each time. So if their PSA last year on their screening was 1, and this time it's a 3.6, right? I'm starting to get a little bit suspicious here, starting to look into that a little bit more, even though it's under 4, right? So we're going to do the PSA. If that's elevated or if it's increased 25% from last reading, then we are going to go ahead and send them to urology. We can order things like ultrasound or MRI. Patients are probably going to be set up for a prostate biopsy by their specialist. And these are going to have treatment for these cancers, chemo, ablations, hormone therapy, surgical resection called a prostatectomy. But again, your job is to screen and send off at the appropriate time. And also, screening for common forms of cancer should be at the forefront of our minds as, especially in family practice. So thinking about those screening guidelines, thinking back to that, the U.S. Task Force currently gives a C for prostate cancer in males ages 55 to 69, doesn't recommend PSAs over 75 at this time, or over the age of 70 at this time. However, again, think about your shared decision making. If daddy and grandpa and everybody all had it, they may opt to have the PSA screening. So it might be right for some people in the right cases. So just thinking about that. Wrapping up today's lesson here on testicular cancer. It's rare. We often see it in young people around that 15 to 45 age range. Prostate's going to be older. Patients with the trauma or the painless lumps, the swelling, the cryptorchidism, all those are going to put the patient at, start raising our red flags of suspicion for testicular cancer. Even infections like HPV or EBV, they can also, again, raise the risk. It doesn't seal the deal, but it can raise the risk for testicular cancer. And again, anybody who has, that unexpected weight loss, fever, fatigue, night sweats, they need a little bit further workup. So anytime we see a lump on the testicle, even if it's painless, we're going to go ahead and refer that patient out for an ultrasound. That's going to be your gold standard of imaging to evaluate further. So the good news for this one is that testicular cancer treatment is very effective. This has a high rate of cure if we can catch it early. Oftentimes they'll actually remove the affected testicle, and then often they can give some chemotherapy as well. So again, lots of things can be done, but it's our job to help screen and educate patients on exactly what to look for and signs and symptoms to report. So that's all I have as far as content goes. I have a couple other practice questions for, and then we'll wrap it up for the day. So if there's anything else that you all want to put on here, you can definitely do so at this time. I have a little matching game for you guys. I'm going to just leave this up on the screen and give you a minute or two to look at it. All of those big fancy words that we just used, you all can look on there and do a little matching. And then I'm going to give you the answer here just in a minute. So I will pause for just a moment and give you all time to look over that. And then I'll be right back with you. All right. How'd you do? I've got the definitions for you. These are the answers to your matching. Tell me how you did in the chat, guys. Did you miss something? And it's okay to ask more questions. Rachel is still standing by. So I'm going to give y'all just a moment to write down anything that you missed, because all these terminologies you could see on an exam, both in school or the boards. And then, of course, most likely, definitely, not just most likely, you'll definitely see these in practice. So take a moment, get your bearings. If you missed something, that's okay. This was a test today. This is just some practice for you guys. So take a minute to put whatever you want to put down for your reference. So I'll leave that up just another second. And then we're going to go ahead and do a question together. And I'm going to let y'all go. Y'all have done a great job today. Y'all have been very interactive. Y'all have gotten just about all of your answers right. I'm so impressed. Really good group. All right, let's take a look at these questions together, okay? So you have a little baby coming in. Jason, 8 months old, is here for his well child. And a mother states the pediatrician has been monitoring an undescended testicle on the right side, and she's not able to feel anything coming down, and she wants you to check today. So you also are unable to palpate the right testicle and order an ultrasound, and confirms that this testicle is in the abdominal cavity. What is going to be our next step? So are we going to reassure mom? Are we going to make a 3-month follow-up to repeat the ultrasound? Are we going to tell Jason's mom to apply a warm, moist compress to the area, or refer Jason to pediatric urology immediately? So he's 8 months old. I want you to think about, what age are we going to send babies out? So remember, cryptorchidism often is present at birth. It will often resolve within 3 months' time. And if it's not resolved by ages 6 to 10 months, then we need to refer. And Jason is perfectly in that window, absolutely. So you guys got it. We're going to absolutely positively refer Jason to pediatric urology immediately, right? Because we know that this can cause testicular cancer risk and infertility risk down the road. So great job, guys. That was wonderful. Y'all did a really great job today. I'm going to leave up. I'm going to just scroll back through here. I'm going to leave this up for you all. Please scan that QR code. Join us for our webinars. We're already starting to get the August schedule lined up. We have some new topics coming for y'all. We have several things coming up in July as well, including that live 3-day review. So we would love to see each and every one of you there. Be sure to take advantage of the Q Bank if you haven't already. And I think we're going to go ahead and call it a day unless there's any other questions. So again, we're here. We'll stand by another minute. There's the email address for you as well. Connect with us on social media or via email. We'd love to hear from you. So lots of things to take advantage of. All right. Well, we'll see you soon.